All set?
Okay, I'm just bringing up my slide deck for you all. And I thought I had enabled the chat window in case there were questions during, but I don't seem to be able to do that with the PowerPoint. So just might need you to speak up and let us know if you have a question. We were taking notes while you were introducing yourselves, and I think we're both just really taken aback by the diversity of the participants in this group, and it's very exciting to talk to so many different folks from so many different disciplines who are committed to survivorship like we are. I'll tell you a little bit about the two of us. We're kind of a dynamic duo. We've been working together for a really long time as a social worker and a nurse at Penn Medicine. We met a million years ago when we were working on the floors together, new to oncology, and fast forward to today, and we're working for a really amazing website called Oncolink.org, which is part of Penn Medicine here at the University of Pennsylvania. We are the oldest cancer information website out there on the World Wide Web. We turned 25 last year, so March will be 26. That's really old for a website in website years, like 110 in dog years or something. So we're really proud of the work that we do at Oncolink for cancer education across the cancer trajectory, from risk assessment and prevention all the way through to survivorship care. And definitely are both very committed to the special needs of survivors, which is, I think, why Janice invited us to come today. I hope you all have lots of questions. We're gonna do a basic overview and then talk a little bit about guidelines and recommendations from a couple of different areas, and then demo for you our OncoLife Survivorship Care Plan tool in case you haven't seen it. We know there's been a lot of changes in this space recently, but just want to give you a tool that you can use with your patients if you're not using it already. Do you want to say anything else? I'm Christina, by the way.
No,
all right, I've said enough apparently. It's a little bit, now you know how the two of us work. Okay, so just an overview of what we're going to talk about today. To save time, I'm not going to tell you this, and we're going to get started.
So we'll kick it off with who is a cancer survivor, and I know that when we listened to all your introductions, we were like, they could probably give this talk, but so we'll give you just, you know that people are considered a survivor from the time of diagnosis. We also point out, though, that in clinical practice, we really think of survivorship as starting at the end of active treatment. And it's important to keep in mind that that does leave behind a lot of our patients when it comes to survivorship needs, people with chronic cancers, people on long-term maintenance therapy or hormonal therapy. And so we want to find a way to meet their needs as well.
So we thought it would be good to just also talk about what we think are 3 key things that survivors need, which is first, support during care transition points. I've heard survivors describe to me when they finish treatment, just sort of like feeling like they're at a ship being pushed out to sea. Good luck, have a great time, you'll be fine. And what we're hearing from survivors is, I'm really scared. I don't know what this means after treatment. I've been connected with my treatment team and seeing them weekly for months on end, and now I'm kind of feeling alone. So we really, really advocate that what survivors need is support during those care transition points, and they can be from active treatment to surveillance. Perhaps when we're concerned that a patient may be having a recurrence or a relapse of disease, that's a transition point. Restarting treatment is a transition point. Transitioning potentially to end-of-life care after relapse. And so really what we need to do is support patients during those transition points, because they're almost like a weakness point for us as a care team, but also for the patients, and how do we build that weakness point up to support them. We also know that patients need education about life after and with cancer, and that can be anything from the physical effects to the practical concerns and the fear and anxiety associated with recurrence. Over the years, I think we've both talked to a lot of patients who just at times really describe feeling crippled by the fear of when is the cancer coming back. And a lot of our work focuses on, well, what if it doesn't come back? And what does that mean for your life in terms of going back to work, in terms of maintaining your health insurance, and working on relationships with your family and friends. Those are important to focus on as well. And then also education about preventive medicine. And finally, our survivors need a plan for their follow-up care and which concerning core symptoms that they may want to report to their healthcare providers. So really interesting. I'm hoping a lot of you heard this fantastic news a couple weeks ago that there was a 2.2% drop in the cancer death rates over the years of 2016 and 2017, which represented the largest decline in cancer death rates in history. Which is a pretty amazing statistic. But that being said, that means there's a whole lot more people that are living with and after cancer, which I think really highlights the need for us to put more emphasis on the needs of cancer survivors. We also know that the number of cancer survivors is growing rapidly. There are some 17 million cancer survivors in the US today alone, and that number is estimated to balloon up to 26 million in just the next 20 years. That is a lot of people who can call themselves cancer survivors. We also know that the population is aging, and that as our population is aging, we're seeing more cancer diagnosis in older persons with multiple comorbidities, in addition to the fact that they're cancer survivors. And we also are seeing a lot of children who are, and adolescents who are long-term cancer survivors, but they often are showing also a higher burden of late effects. So while it's great that the death rates are declining, the needs and the numbers of survivorships, our survivors are greatly increasing, and the people with cancer are living longer. I think it's also really important that we mention that while we've developed such an amazing number of new treatments, targeted therapies, and immunotherapies, the truth of the matter is we don't know what the long-term and late effects of those treatments are yet. And so 10 years from now, we could be having a really different conversation about survivorship needs based on what some of those late and long-term side effects that those patients do experience. And finally, this is the social worker in me coming out. I do a little work on the side with patients who are coping with financial toxicity, and the studies that, or the stories that I am hearing about patients and what they are suffering as a result of the cost of their care and being underinsured is really, really terrifying. And certainly in crisis mode, we have lots of, I think the last thing I read was that the #1 cause of personal bankruptcies in the United States is medical debt. And it's also very concerning to me that lots of people are turning to crowdsourcing and fundraising as a way to finance their cancer care. And I think that's a really sad statement about the state of health insurance in our country. And I think something our patients are going to be talking about long after they complete active treatment. So just a little overview of the history of survivorship care. I'm sure, like me, you have on your bedside table the Institute of Medicine report from 2006, From Cancer Patient to Cancer Survivor, Lost in Transition. This was really such an important text because it was really the first time that awareness was being raised about the consequences of cancer and cancer treatment. And if you think about it, that was only 14 years ago. I know that when I first started working in oncology, a whole lot less people survived the cancer diagnosis and their treatment. And as I just mentioned before, we know a lot more people are surviving. But we haven't done a lot of work in that 14 years, and we still have a lot more work to do. This report discussed that a lot of primary care physicians had a generalized discomfort with caring for cancer survivors. You know, give them a hypertension or a diabetes case, they'll do that, but you throw in a patient who has a history of breast cancer or lymphoma or thyroid cancer, and they're going, how do I manage this? And so this report really recognized that generalized discomfort. So they made some recommendations for the first time that all survivors and their PCPs should receive both a treatment summary and a survivorship care plan, and really, really honed in on this idea that survivors should be and need to be active participants in their post-cancer care.
So most of you on this call mentioned, or a lot of you on this call mentioned being the people who are developing treatment summaries and survivorship care plans. I always like to stop for a minute and just point out the differences between these two documents, because they really were meant to be two different documents. The treatment summary I often refer to it as the provider-facing document. It's a great thing for a survivor to get a treatment summary and file it away in their files, but it's not something that's providing a whole lot of useful information to them because they lived it. When it comes in handy is 10 years from now when they have some other health crisis and somebody says, well, what was your cancer treatment? And nobody can find the records, or, so they have a copy of it. But it's not really helping them ease that transition point that we talked about into survivorship. So I think of the survivorship care plan as the patient-facing document. So the piece that really is the thing to hold their hand, help them understand about late and long-term effects, what kind of things to look for, how to live healthier, what kind of cancer screening they need, symptoms to report, and then, some support and resources for all the practical issues that they're going to face after treatment.
So we like to think of this 4 Ps of survivorship care as an easy way to think about what it is that patients are needing at these various transition points in survivorship care as prevention, palliation, health promotion, and practical and psychosocial management. So prevention really focuses on prevention of those late effects or potential second cancers. And that might include things like osteoporosis prevention, or even mammograms after chest radiation. But it also might include those recommendations for continued management and monitoring. We have a lot of patients who have questions about how often do I need to get labs? How often do I need to get scans? How do we prevent, if we can, recurrences from happening, or at least find them earlier and give us more potential success for subsequent treatment? It also might include things like vaccines and other standard cancer screenings. Palliation is the palliation of ongoing symptoms that may be occurring as a result of cancer treatment. I love a really global, broad definition of palliation. I'm trying really hard to get people to stop thinking about palliative care as only in just the sickest of the sick or a sort of step to end of life care. We really need to palliate symptoms in our cancer survivors as well. Cancer survivors certainly experience things like pain, fatigue, and anxiety, all of which need to be managed so that we can help the patient have quality of life after their cancer treatment. When it comes to health promotion, we're talking about educating our patients about things like diet, tobacco, alcohol use, exercise, sleep hygiene, mental health care, and again, back to those cancer screenings that they need to get. I always said to my patients, just because you had cancer once doesn't mean you're not going to get a second cancer that's totally unrelated to that first one that you had. You still need to get the mammograms. You still need to get the colonoscopies. And that's really a space that we can really be helpful in providing that education to our survivors. And finally, the practical concerns. Thinking about going back to work. Can I return to work? Can I do the same job that I used to do before I had cancer? Or has the neuropathy from the chemo I gotten keeping me away from being able to do the essential functions that I was able to do in my job before? Do I need to think about vocational rehab? How do I maintain my insurance? How am I going to pay the bills? What if you're dating again after cancer? How do I tell a potential new partner, oh, by the way, I had cancer 5 years ago? All of that stuff is really important for us to think in that P of practical and psychosocial management for our survivors.
So we thought we'd touch briefly on survivorship care models. So after the Institute of Medicine report came out, centers started formulating how they would provide some survivorship care for their patients. And they sort of naturally fell into a couple groupings, I would say. So the academic or oncology-based programs were generally programs that started at a cancer center. In the early days, they were often formed around a particular disease type. So maybe it was a specialty survivorship clinic for breast cancer patients, or maybe a treatment type, people who had gotten stem cell transplant. And then patients would be ongoing followed in these programs. And the disadvantage there being that you're missing the piece of health maintenance and prevention that you get from a PCP care. And then we had some community-based programs which really formed in the community, and they were being provided by the primary care physician who maybe had some knowledge of cancer survivors, but maybe not quite enough. So then came along the shared care model where the patient would be seen in both settings and see the oncologist periodically or as on a consultative basis. So these kind of three areas of survivorship care can be carried out, I guess you could say, in a few different ways. One being the consultative model where the survivor would be seen once in the survivorship clinic and they would provide a report that would be sent back to the PCP and the primary oncology team who would carry out the plan. An ongoing program where they are, the survivor is followed long-term in a survivorship program and basically discharged from their primary oncology team. And then the integrated programs where they're getting their survivorship care from the oncology team that treated them for their cancer. And there's a lot of pushback to do this because for the provider, from the provider's perspective, they like seeing patients who are doing well, good for their mental well-being. But on the other hand, we have a booming number of survivors and a shortage of providers. So the integrated model just isn't going to work out. So we have to think differently about that. So the future direction of survivorship care has kind of shifted from a one-size-fits-all approach to one that offers the right services to the right patient at the right time in a cost and resource efficient manner. So you might be thinking, back up.
Sorry.
Well, you might be thinking that, I did just describe multiple different approaches, but generally these models were being used to address survivorship care for all the patients in a practice, regardless of their risk or their need. So if your practice had a consultative oncology-based survivorship program, then all of your patients, regardless of their risk or needs, would be seen in that program. And you can see where there are some patients who maybe don't need that intensive survivorship visit. And then there's others who probably do need it and maybe don't get it. So now we're moving towards a needs-based model. So this was one model recently put out by a task force to look at risk-based strategy for survivorship care. And to me, I know they put a lot of time and effort into this beautiful graphic, but it feels like a no-brainer, right? So people who are in the low-risk category, maybe early-stage cancers, people who got standard treatment, and their cancer-related needs may be pretty low. So their attention, their medical attention really is on long-term other comorbid conditions or any other health maintenance needs that they have. So being managed by a primary care provider makes a lot of sense. And then, if they need some help from the oncology team, they can refer back to them. This model was set up with the intermediate risk being individuals who had less common cancers, maybe treated at a later stage or got more toxic treatments like chemo-rads or stem cell transplant. And these patients can probably benefit from a shared care-based model with input from the oncologist routinely, and then ongoing health maintenance and management of chronic conditions by a PCP. And then if they have late effects or concerns, they can consult with a specialty survivorship provider. The high-risk individuals were thought of as people with advanced stages or requiring complex medical treatment or having pretty important long-term or late effects.
Sorry, the chorus of beagles is about to break out. I think I just want to go back to saying too that I want you guys to be thinking about these models and maybe what you have in place at your settings, because I think it's going to be really important when we get to talking about the new guidelines proposed by, or now in place by the Commission on Cancer. So I just wanted to go over a few organizations and their guidelines and recommendations, because there is more than just the Commission on Cancer. The American Cancer Society also has made some recommendations, which includes, and I think as a social worker, this is really important to me too, the implementing of a routine needs assessment of survivors and caregivers. And I think what I love about the ACS is they're really one of the only groups that really puts the emphasis on what is it that survivors need and their caregivers need, and really asking those questions and developing and augmenting our programs based on some of those answers that survivors tell us they need in that needs assessment. The ACS also feels that it's really important for us as providers to give personalized information and referrals from diagnosis onward for, again, both survivors and caregivers. Again, I think that's also a really important thing about the ACS recommendation is they also put a lot of emphasis on the impact of cancer care and treatment, those consequences of cancer on the caregivers as well. And I think we know cancer doesn't happen in a vacuum. It happens to the patient and all the patient's friends and supports and families around them. So I love that they also put some of the emphasis on that, as well as disseminating and supporting new care methods and intervention. I mean, I mentioned that the state of the science of survivorship is actually pretty young, you know, since 2006. So how are we going to move forward with survivorship care as we learn more about what some of the long-term and late effects of our new treatments, which are fantastic, and how they affect patients in a long-term setting. The NCCN also has some recommendations that says that the care of the cancer survivor should include that prevention of new and recurrent cancers. There's one of those 4 Ps, surveillance for cancer spread or recurrence, assessment of those psychosocial and physical effects, so more of those Ps, intervention for consequences of cancer treatment, and really they spell out that survivorship care planning is essential to the care of the cancer survivor as well. Then we have the NAPBC, the National Accreditation for Program on Breast Centers, and I probably should have put the second bullet point first, which was that at the end of 2017, facilities that had the NAPBC accreditation were supposed to be shooting to be giving survivorship care plans to at least 50% or more of their eligible patients who have completed treatment, and then by the end of 2018, you are also supposed to have into place a comprehensive process to prepare and disseminate those care plans to all eligible patients, which I think about going, wow, that's a huge task. They did really define, again, those eligible patients. I think it's really important for us to think about the patients that are not eligible as well, but those are the ones that are concerning to me, those stage 4 patients who still may be living a long time with metastatic cancer, but just because they don't meet these guidelines to be eligible patients because they weren't treated with a curative intent or diagnosed with a stage 0, 1, 2, or 3 breast cancer, I just get concerned that they're getting lost in that transition point. I do appreciate, though, that NAPBC does recognize that breast cancer treatment goes on for years with hormonal treatments after treatment, and so those folks are still considered eligible. And then we get to the Commission on Cancer. And I will say that Carolyn and I met with folks at the COC because they just also happen to work at Penn. And we worked really hard and talked a lot about what we knew were going to be changes to some of the requirements in survivorship care. I also know from having worked in a clinic how hard it was to implement the survivorship care planning standard that the Commission on Cancer had set forth about 5 years ago. So it wasn't surprised that they had changed the recommendations going forward. So these were implemented just a few weeks ago on January 1st. So these will first be reviewed during surveys starting next year. And the big changes are that the facilities that are accredited by the COC are now required to designate a leader of the survivorship program. Now, let's just be clear that the COC did not stipulate that you needed to create a new position or a new hire for this. It's really supposed to be a member of the cancer committee already in place. They're taking on another role. So when I was in the cancer committee, I was the psychosocial coordinator. I very well could have served as a survivorship program leader as well. Under that, then the survivorship program leader is to identify a team within that cancer committee and outside of the cancer committee and the cancer delivery service line at your setting, that it's going to identify services and programs that are going to be offered to address the needs of your cancer survivors. And one thing that we want to tell folks is if you're already doing survivorship care plans, that's one of the services that you can continue to do. You're already doing something, and the COC continues to recommend or to recognize that. So that can be one of your 3 programs that you report on. But it could also be treatment summaries, screening for recurrence, community education programs, nutrition programs, support groups, exercise programs. Maybe you want to hire a financial support person to help people after their treatment deal with their financial toxicity. Maybe your patients need referrals because you see an uptick in folks who are having cardiac toxicity after chemo, and you want to have referrals to cardiac oncology. All of those are types of programs that you could develop under your cancer survivorship program. You then need in your SAR to report on 3 of those programs, which include an estimate in the number of patients who have participated in your program and identify barriers and resources needed to address. We also found it interesting that there is 0 benchmarking whatsoever. They don't give you any kind of, you need to offer survivorship care to 100 patients, you need to offer survivorship care to 1 patient. There's just none of that, all of that language of percentages and eligible patients is gone from the Commission on Cancer Standard, which I think is interesting. And maybe I like that they've taken out eligible patients because now it really allows us to provide survivorship to all folks who are cancer survivors. But it's concerning to me that we don't have a lot of ways to kind of move the needle and show that our programs that we're planning for patients are actually impactful and, again, patient-driven. So we found those were kind of interesting, but we want to say if you're already doing care plans, and it sounds like a bunch of you probably already are, that if it ain't broke, you don't have to fix it. Mm-hmm. And that there are ways that you can meld that into your review with your Commission on Cancer accreditation and say, hey, we're doing this. And then I would say, think about ways that you can collect data and metrics so that you have that estimate in the number of patients who you gave care plans to over the course of your year. So we just thought we'd highlight a couple of resources. We're going to come back to Oncolink. Why does that URL look so funny? But then we just wanted to make sure everybody knew that ASCO does have some pretty, would you say, generic?
Yeah, so they, I mean, I'm sure many of you have seen them. They have basically templates for the major cancers and then a generic one. From my own personal perspective, I see those as treatment summaries because I don't think they provide a lot of patient-facing material, which I've given you my opinion on that. You may feel differently and do as you may. But yes, they have those templates available for use on their website.
Also, George Washington's National Cancer Survivorship Resource Center has some great resources available. And the NCCS has various survivorship checklists for patients to print off and take to their providers and say, I want to talk about this. Those can be really good tools as well. And then both Carolyn and I have seen in our roles at Oncolink, also just the development of embedded survivorship information within various EHR products. And so that may be something that's available to you at your specific treatment facility, depending on what EHR product that you're using. So let me go out of this and go here. You guys can still see my screen. Why is my mouse being funny? So we thought we would just show you a little bit about our tool because we are very proud of it. This is the Oncolink Survivorship Care Plan tool, which is available at oncolife.oncolink.org. And I'm gonna go ahead and sort of click through and show you what we can do. And Carolyn's gonna tell you a little bit more about our tool.
Yes, so I'll give you some of the background while she's doing the creating of the care plan. So this tool was launched in 2007. Our team, went to many conferences where we'd hear about the need for survivorship care plans and how are we going to do this. And we thought, I think there's a way we can do this. So we built it. We do track usage statistics. So we've had over 80,000 care plans created in that time period.
And this is just a little of this is all of really the demographic information that we collect. And as you can see, different than the ASCO, we actually are able to ask about all of the cancer types. Mm-hmm. So we're going to do a breast plan because it sounded like a bunch of you were from breast centers. So we'll just show you what's available.
Mm-hmm. The care plan is also available in Spanish, and we did it in a way that we have either a Spanish interface if you were in a Spanish speaking clinic where the clinician spoke Spanish, or you can do it in English and then in the end print a Spanish result for your Spanish speaking patient.
And you can see here, these are all of the drugs that are associated with breast cancer treatment. So you would just check off the ones maybe that your patient has received, as well as with breast, you can check off their hormone therapy. Way back in the day, there were lots of women with breast cancer who had bone marrow or stem cell transplants. Doesn't happen so much anymore, but that's why we have that content into that page as well.
We recently did a presentation at, was that APOS?
Which one? The International IPOS.
IPOS. And presented on the international usage of the care plan, which was pretty, we hadn't really looked at it prior to that, and so it was pretty interesting. Just before she skips ahead, that box, it's okay.
Okay.
That box, you can type in anything you want. So some centers will use it to add in, our support group meets on Tuesdays, or whatever it is, your follow-up appointments in 6 months, whatever you want, you can type in that box and it will be included. And then you have this page where these are the things that are going to be in your care plan. If there was something that you felt was not relevant for this patient, you could uncheck it. We had people ask us to build that in, and to be honest, we only see about 1% of care plans have something removed. So,
and that only shows up in the HCP version.
Right.
And then this is what the actual end product will look like. These are the tabs here that highlight the various sections in the care plan. And then our patients or healthcare providers who use the tool can download the care plan here, print it, go back and edit it, or change it to Spanish here and download. You can also choose to email your care plan. So say you are a provider and you want to email it to the PCP, you can do that right there within the care plan. We had a lot of patients or folks who asked us about patients with multiple cancers. This version doesn't allow you to say, well, I've had 3 different cancers and check all of them off. But what you can do is go here, this patient had another cancer diagnosis, and it automatically populates those demographics you've done at the beginning, but allows you to choose that second trajectory of cancer, and then populate those things for the treatments that were received.
And then just open a PCP Zoom. So there is this healthcare provider summary. So one of the complaints that people had early on was, a care plan is pretty long, but we want the primary care provider to have this information. So we took like a bullet approach of all the late effects, and it is meant to be printed out and given to the either primary care provider or their other specialists that they see. So it's kind of hits the highlights. So in the care plan, we pretty frequently update to add new medications that come out and side effects associated with those. We use mostly NCCN for the follow-up guidelines, and we update those every 6 months. There are a few cancers on our list that do not have NCCN guidelines, so we use either best practices or things that we find in the literature, or just discussions with experts.
And I'll just download so you can see what the actual care plan. You saw that that healthcare provider summary was 5 pages. The whole care plan itself here is 19 pages. But I think we also want to highlight that it took us about 4 minutes to actually complete the care plan. So we hear a lot from professionals that it just takes too long, or they need to go back into the chart and find out what the treatments are. Also remember too that this is totally available for patients to also complete on their behalf, and this is available as part of our website free of charge. So that's just an overview of our Oncolife plan.
And the other thing I would point out is that one thing that we've been hearing and we've been thinking about ourselves is that if the COC is not requiring places to do survivorship care plans, will people move away from that? And I mean, my hope is that centers that are already doing it and doing it well will keep doing it. But maybe the centers that choose not to, they still want to provide survivorship information. So we've started working on creating survivorship education to host on our website. So rather than having you build a care plan, you could go and print a document about lung toxicity after radiation or some, you know, some late effect. And be able to support your patients with just individual teaching handouts as opposed to a whole care plan, if people choose to go that route.
Okay, so that's the gist of our presentation. We have some time for questions if you have them. I'm going to stop share, and my chat box is enabled if anybody wants to chat, or if you just want to throw a question out, that's fine with us too. Or any thoughts? Love to hear more about what you guys are doing too.
Christina, given the amount of where we are in terms of time, I certainly want to allow people to be able to ask questions, but in the interim, do you mind also sharing an email address that you'd like them to use if they have additional questions and don't have time to ask them today or something comes up later?
Sure, Janice, that's included in the slide deck that I sent you. It's the last slide. I just got out of it before we got to there. So we'd be happy to entertain emails that you have if you have questions for us.
Very good. Okay, we will send out that slide deck as a PDF. All right, well, thank you. That was very informative. Who has questions that they'd like to pose to Christina or Carolyn?
Hi, so Ananda, just want to say thank you for telling us the patient-facing versus HCP-facing. We do think it's also like really a helpful for us way to break down, because we do hear people using the treatment summary and SCP kind of interchangeably, and we really want folks to be thinking about the differences there. And Patty, yes, Janice has the presentation and she'll share it with you. And yes, we're very proud of being available in Spanish. We're really the only one, right? Mm-hmm. Yeah, so.
That's awesome, thank you.
Mm-hmm.
Hi, this is Teresa Labovich from Penrose. I have a question. Have you, in terms of the programs that the new COC requirement speaks of, do you have any ideas of what the interpretation of that, what people are thinking they might want to implement, what that looks like?
Personally, it feels like the wild, wild west a little bit to me, especially for this first round of surveys. It's going to start next year. I feel like they're kind of throwing things at the wall and seeing what's sticking. So I think that in that respect, it's a great opportunity for programs to build survivorship programming at their centers that again goes back to what are the needs of our patients. And I love that model that Carolyn used about the low risk, medium risk, high risk. Maybe it's thinking about developing one program for each of those 3 types of patients. There's your 3 programs right there. And maybe you say my high risk patients are all going to get survivorship care plans or whatever. And the low risk programs we're going to aggregate into nutrition and exercise classes. I mean, I think there's a lot of room for us to kind of figure out what might work best in our settings for those patients. So I don't know what they're going to be looking for. It's going to be very interesting to see what that looks like in a year or so.
Thank you.
Mm-hmm.
And you kind of think they can't fault you for anything you do because they didn't give you any guidelines.
I have a quick question. This is Jackie. I'm the preventive medicine resident. How difficult is it to, or is it even possible to integrate this template you've been using into various electronic medical record systems?
What a question. Well, we actually are working on a project with Epic in our home institution, but fully realize that it's taken months and months to even move the needle in our own institution. So we know it's a long way before it's ready for prime time. I mean, there are some EMRs out there that have incorporated some level of survivorship care. We also work with Varian Medical Systems, has a EMR product that they use our stuff in. You know, it's difficult because so many of these EMRs and so many places use Epic and they just don't play nice in the sandbox. You know, they make it really difficult to integrate and work within those programs. You know, the one thing we didn't mention that we've talked about with the COC regarding the treatment summaries is that so many programs have really strong cancer registries. And I know I've heard somebody speak from Colorado about the Colorado registry and how strong it is, and that somebody is already doing the work of pulling together a treatment summary in your cancer registry. And, you know, a patient doesn't need their treatment summary the day they're walking out the door. They're not going to need it for probably a few years. So, you know, we suggested to the COC that using the cancer registries as a way to disseminate treatment summaries seemed like a good way to do it because, you know, maybe they don't get the information for 6 months, but it's okay if a patient doesn't get their treatment summary till, you know, 6 or 9 months after. So that's one way to tap into using what's already happening in your, you know, hospital systems. That's a little dance around, no, we can't use it in the EMR at this point.
We have seen some workarounds though with people, like if you're in Epic, which I've been in before I was in this position, we would oftentimes download that PDF copy, that medical summary that Carolyn showed you, and scan it into the documents in Epic just to document again that it had been done. So we've seen some settings who've done that in their places as well. So
one little question: is it available in Word format by any chance?
No.
That would make it really easy to slide it into the VA system. That's all.
Okay. Well, you know what the worry there is, that it's copyrighted material, and then we worry that people, you know, do what they want with it, and it still has our copyright on it. But that's interesting to know because we've wondered about the VA systems and how.
But maybe connect with us via email too, and we could continue talking about options for that. Because I mean, that's another really specialized population as well that I think could benefit from care plans too.
And then the question about people providing financial assistance. I mean, I don't know what other people in the group can say, but I think a lot of that remains to be seen. I think there are some centers out there that the leadership really believes in survivorship care, and they will continue to support it financially, but obviously there's going to be programs that
don't have that. And I think that goes back to keeping data and developing metrics for how much work your survivorship team is doing. So if you're able to go back to your cancer committee and said, we serve 700 patients in these programs, and we have a lot of really great feedback from them, but we need more bodies to help us do this, that means a lot more than, oh yeah, we had some people come to a program. So I think if you are embedding how you're collecting data about the usage of your survivorship programs, that's going to help you in the long run maybe be able to justify creation of positions down the line. And I will tell you, just in general, the financial counselor world is also just like the wild, wild west, because we just don't know, like, who's a financial counselor? Is it a social worker? Is it an MBA? Is it somebody who has a high school diploma? Those, all three of those kinds of professions are doing financial counseling. There's no standards for it. And I think that's another space that we need to do some work on, because I'm concerned about quality of care. So think about that when it comes to financial assistance, financial counseling.
Christina, I apologize for having to wrap this up, but we have a couple of business items we need to cover.
We
So
appreciate it, Janine.
this is a,